make it easy to qualify for people with complex medical conditions. And then, so then this is splitting that 15 to 25 into different age groups. You can see that, and these are the same colors. So, sorry, just a sec. At ages 15 to 18, there's a lower prevalence across basically all states in people who have complex medical conditions compared with ages 23 to 25. So at ages 15 to 19, the highest prevalence is about 6%, but at ages 23 to 25, Texas, for example, enrolls about 18% of the population in Medicaid in Texas between the ages of 23 and 25 have a complex medical condition, which, given that this is like 4% of the population overall, is actually kind of amazing that it's that high in the Texas Medicaid program. Okay, now to formally look at, so those were just sort of giving you general population prevalence numbers among the states. Now we're going to formally look at disenrollment. So disenrollment in this case means 2 consecutive months not in the eligibility file. So we see the way this file is structured, we see everybody's eligibility month to month. When you drop out for 2 or more months, we count that as a disenrollment. If you don't merge into also the files are done by year. If you don't merge into the next year's file, we consider you disenrolled, although that's a minority of our observations. The primary independent variable is going to be age. That's what we've been talking about the whole time. We're going to measure enrollment at various ages. We're going to use a discrete time survival analysis, and then I'm also going to show you at the end some Kaplan-Meier survival curves. Okay, so this is the main regression specification we use. It's basically just looking at, I don't know what time okay. So the regression specification has an indicator for indicator condition, and then this summation term here just is showing you that we enter age as an indicator, or as an indicator for each year. So we're going to be able to generate, we're not imposing linearity, that's the word, sorry. Linearity on this. We're going to have a different estimate for each age individually. And then the second summation term is that we estimate this for the complex population separately. So we have an estimate for each age for complex and non-complex. Then we have, in some specifications, though not in the main ones, we include covariates. And then we have state and year fixed effects in all specifications. I'm going to give you the results as either marginal effects or as predicted probabilities. And then all of these are conditional on being enrolled in a previous year. This isn't cumulative disenrollment for all until we get to the Kaplan-Meier curves. So this is just the independent probability of being disenrolled at age X if you were enrolled in age X at age X minus 1. So looking at some results, this is the predicted probability of disenrollment by age, beginning again at age 16, because the youngest ones are 15, they're enrolled for those 11 months. So you can see that the probability of being disenrolled at age 16 is pretty low, but then it spikes at age 19, and this is for the full US, and then declines a little bit, but remains high. The blue line is the non-complex population, and the red line is the complex population. So as we can see in the general prevalence, people who do not have a complex medical condition have a much higher probability of disenrollment, but there's still the same patterns in the complex population. Okay, so this map shows you this spike at age 19. We generated that's a beta coefficient. We generated those beta coefficients for each age and for each state. So this is the beta coefficient on age 19 for each state, color-coded. So what we interpret that as is the probability of disenrollment at age 19 in each state. So you can see, again, that there's a huge variation in whether you are likely to be disenrolled from Medicaid at age 19, depending on where you live. So in certain states, Montana, Oregon, Michigan, Maine, for example, you're less likely, much less likely to be disenrolled than if you live in Wyoming or Mississippi, Alabama, or Oklahoma or Pennsylvania. And then this is just, this slide. We're going to turn to the patterns by state now. And you can see that the patterns vary quite a lot depending on the state that you live in. This is just, 50 of these. We have 50 of these. That would have been a lot for one slide. So this is just 3 to show you how these patterns can be different. So in New York, for example, there is no spike at age 19 in disenrollment. Instead, the probability of being disenrolled grows up till about age 22 and then kind of flattens out. Colorado has a spike, especially for the non-complex, and then the complex, a much smaller population, is a little bit messier of a pattern. And in Florida, there is there's a spike at age 19 relative to earlier ages, but then it remains high up until age 22. So turning from states to different body systems. So you can see that for when you look at the individual body systems involved in the complex condition, the patterns look relatively the same. And you probably can't see this all the way in the back, the magnitudes are much different. These axes, the y-axis is different for these conditions. So for example, the spike for malignant conditions up here at age 19, this is almost 25% disenrollment. But down here for neurological conditions, this is about like almost 12% disenrollment. So this spike is half the magnitude of this spike. So again, the patterns, when we looked across conditions, the patterns look the same, but the magnitudes are much different. And then this is just graphing the beta coefficient for age 19 among the different among the different body systems that could be involved. And again, you can see the different magnitudes. So malignant here, again, is the highest, almost 25. Neurological, almost half that. And you can see like a genetic condition is even lower in terms of the magnitude of disenrollment at age 19. Okay, so now like I said, this is probably our most preliminary result at this point, but we are beginning to add covariates to the regression to try to figure out if we can, these aren't causal, but if we can correlate some various either individual or state-based policy characteristics that might correlate with disenrollment. So people that have more body systems, a negative number here means less likely to disenroll, or probably the more intuitive way to say that is more likely to stay enrolled. So this first line, somebody with an additional body system of involvement has a 2 percentage point increased likelihood of remaining enrolled in Medicaid in each year in this time, across ages 15 to 25. Females have a slightly increased likelihood of remaining enrolled. Socioeconomic variables within a zip code did not seem to matter. Those were pretty precise zeros. For both, this is percent Black and percent no college. We also had entered percent income, also had no effect. But then there are some state-based policies that did have an effect, particularly if a state had a medically needy pathway for enrollment, and if a state had a home-based transition waiver. Interestingly, Medicaid expansion had no effect in the complex population. We're still sort of thinking through why that might be. And finally, this is a Kaplan-Meier curve. So this is measuring disenrollment in a different way. This is, instead of disenrollment conditional on probability of enrollment in the previous year, this is measuring the cumulative probability of disenrollment beginning just before somebody's 19th birthday. So the 0 on here is basically 18 years old and 11 months. So then starting at age 19, you can see that for people starting at age 19 and running out each year, so age 20, 21, 22, you can see that if somebody's enrolled at age right before their 19th birthday, if they don't have a complex medical condition, about 2/3 of those people will disenroll before they turn 22. For those with a complex medical condition, about 1/3 will be disenrolled by the time they turn 22. So to my mind, this is actually a pretty big attrition from the Medicaid system right around this age. Okay, that's the results. The limitations on this study are, I think the main one is that we are only looking at Medicaid claims data. We can't really see where people go when they disenroll, so it's possible they don't disenroll from insurance overall. They may go, for example, to private coverage. Previous work, not on this specific population, but on other populations, suggests that from Medicaid, most people transition to uninsurance, but we can't see that directly in these data. Another limitation is that we identify medical complexity solely through medical claims. There are a lot of ways to define medical complexity, and we are limited in the claims data to using just those. Another thing is the TAF data that we use are very well known to have data anomalies specific to each state. So we took a lot of care to use only states where we felt like the data was valid. We do a lot of sensitivity checks in the paper, looking at what happens if we exclude this state or the other state, but it's definitely possible that we've included a state where the data are biased. Okay, so wrapping up, what did we find? We see a huge spike in disenrollment at age 19. For the complex population, this is basically comparable to the rate of disenrollment in Michigan's Medicaid expansion population. There's not a lot of good estimates of churn. This is one that I know because I helped work on it. But in that population, we found about 20% rate of disenrollment within a 12-month period among the Medicaid expansion. And that's basically what we're finding in the complex population, which to my mind is somewhat worrisome because the complex population is a much more vulnerable population than the general Medicaid expansion population. This is also about 2 times the rate of sort of regular Medicaid churn, according to Kaiser Family Foundation estimates. We also found a high degree of variability in the risk of Medicaid disruption by both health condition and geography. So I think, hopefully that was clear looking at different states. It really depends on where you live and what specific condition or conditions you've been diagnosed with, whether or not you will have your insurance disrupted at age 19. And then again, just preliminarily, we've found some state-based policies, particularly having a home-based community services transition waiver associated with lower risk of disenrollment. Okay, so the policy implications here, I started with talking about the fragmentation of health insurance. And this is sort of a new way that we're highlighting where your geography is your destiny in terms of whether or not you'll be forced to change health insurance or find new health insurance. And we've also highlighted, I think, how a specific diagnosis can be your destiny in terms of needing to find new health insurance. This disruption likely disrupts other care patterns, particularly in this heavy user population that needs regular access to medical care. And then finally, an economic implication is that sicker patients are more likely to stay attached to health insurance. So if states are considering expanding their Medicaid programs, they likely will not be able to use the average cost of current enrollees to forecast the cost of potential future enrollees because those sicker patients are more likely to already be enrolled in the program. Those whom they might expand it to would probably have a lower cost. Okay, that's all I have. Thank you so much for having me, and I'd love to discuss any of this with you all.
This on? Okay, thank you so much. I really enjoyed this, and I've got a few questions. Some of them are kind of wonky about the data, so I'll save those for later. But for the overall, I was wondering if you see a difference in managed care versus fee-for-service states, and just if you have thoughts about that. I'll let you answer that, and then I have another.
That's a really good question. We haven't looked at that yet. There are if you want to just look at a gross like policy level, I'm not sure how many states are 100% one way or the other. My sense is it's only like a small handful that would be 100% one way or 100% the other way, so we could compare those. And we haven't, but that's a good question.
Thanks. And then I also want to ask, do you see re-enrollment? Like if somebody is disenrolled, like I have a family member with a complex medical need, and like they did a lot to try to prove the case so he wouldn't get bumped off at 18, 19, but he did, and they had to get re-enrolled. So just curious if that is something that you see and how you factor that into the survival curves.
Yeah, that's a really good question. We have not looked at re-enrollment. We've talked about it a lot as a research team, and there's some complications with it, including whether or not you and I can probably talk about this, but I don't know that they would always have the exact same beneficiary number. Okay. And the other thing is we were sort of trying to do this first and then maybe look at re-enrollment later. So we haven't, but it's a really good question. And some of the other studies have looked at both disenrollment and re-enrollment later. But yeah.
Cool, thanks. And then I was gonna ask, do you see denied claims? And also, I don't know if that factors into your analysis at all, but that's something we've just been paying more attention to recently. And so I'm just curious if you see.
We haven't looked, yeah.
Cool, thanks. I'll leave it there for now. Thank you.
Thank you. I'm a bit confused about how I want to ask the question. So you said twice that zip codes have no difference or make no difference in sort of socioeconomic delivery, I guess. And then the second part to that is you said that geography does impact. Isn't geography tied to particular zip codes?
That's a really good question. I apologize for being confusing. What we found was no association between the socioeconomic characteristics of your zip code and the probability of disenrollment. We did, though, find differences among states, right? So that, but not if you look specifically across all states. For example, at zip codes where there is a higher percentage of white residents did not have higher rates of disenrollment than zip codes with higher percentage of, say, minority residents. But that doesn't mean that they don't necessarily, I mean, we were looking at like gross zip, I mentioned it as zip code because we're looking at like aggregate characteristics across the zip code. That's the only way we can get some of those socioeconomic demographics in our sample. So it's just aggregate characteristics of a zip code. It doesn't have an association with disenrollment in our study. Mm-hmm. Yeah.
Some parts of the city, I see it all the time. Others, I never see. So that's I'm just trying to wrap.
Eligibility for Medicaid? Yeah. So this is only people who are already in Medicaid. If you live in, say, let's just use income. If you live in a zip code that's high income, if you're already enrolled in Medicaid, you're not more likely to disenroll than if you live in a poor zip code in our study. There's some other work that doesn't show those results, but this is just sort of across this like narrow age band transition and for people with complex medical conditions.
You said your capture rule was based on 11 months of continuous enrollment. I'm wondering how confident you are that your capture rate is well served by that rule. I must say that I mean, a long time ago, in the mid 80s, I did a bunch of work on Medicaid disenrollment, and we had 3 or 4 states worth of data at that time. I don't remember the details, but I do remember that the overall churn rate was about 5% per month. And if anything like that applies, then finding 11 months of continuous enrollment becomes a lot less likely, at least in the overall population anyway. I can't say anything about how that would have applied to the medically complex.
Right. So we lose about 43% of the sample when we impose that rule, which is, kind of would match with some of what you probably saw. We need to impose that rule because you need to have a significant, one thing, this number's lower than we would have expected based on, so this is 5.2% of the overall population. We would expect at least that high of a percent in Medicaid. This uses 3 years of claims data. This imposed a 3-year continuous enrollment. We only had 11 months, and you really can't apply this algorithm in a valid way without at least a year, like 11 months of claims data. So we felt like it was like the minimum possible continuous enrollment criteria we could have. So it's a limitation. You're totally right. We just felt like we couldn't get around it because you need to see how many times people are going to the doctor with specific chronic conditions to find whether or not they're medically complex in a way that's valid.
I mean, did you think about using an alternate rule, like looking for people who had 6 months of enrollment within a 12-month period, for instance, and call and
Again, we need at least 11 to 12 months in order to separate the medically complex from the non-medically complex. We need to have a long period of enrollment.
Any other questions?
Hi, do you have a sense of like how much of the effect is coming from, I know you mentioned it briefly, but from like SSI adults redetermination? Because I know that like that's a huge way that a lot of these folks are going to be getting categorical eligibility for Medicaid. Yeah.
No, that's a super good question. Like I said, I presented this last week and somebody had the same question, and we haven't looked at that yet, and we intend to. So I think our sense is that a good amount of it's coming through SSI redetermination because that is a way that many people qualify, and in many states qualify automatically for Medicaid, and you need to be redetermined at this age. But we haven't looked specifically at that in this population. It's we will.
We do have someone online who is interested in seeing the map again that shows the levels of disenrollment across states and wonders if they could hear more about the reasons for variation across states.
That's a very good question. I think this is a map they're talking about. We don't know. This research is, I think, brings up as many questions as answers, right? So why is Pennsylvania so high? Why, I don't know. I think this research is intended to give us some of that baseline information that would then lead to further studies to figure out what's driving this variation. I showed a couple of correlative things in terms of state-based policies. That's really preliminary. Some other people have had, Shelby and, sorry, I don't know your name, but really good suggestions about like managed care or SSI redetermination. I think it's all of those things. It's also the waiver participation. It's the underlying population demographics, Medicaid generosity. I think our purpose in this is to really describe this variation and the extent of the variation, and then hopefully that will lead to future work that can sort of point to various policies that may or may not lead to disenrollment or continued enrollment through this young adult period.
We have another question. Someone, first of all, they give you a huge compliment and say this is a sophisticated quantitative analysis. But they have questions about, with so many limitations and exclusions and any claims data through 2019, what can this really tell us in 2024 about socially significant real-world outcomes and needed policy solutions that cannot be inferred from known deficiencies in Medicaid eligibility regulations and also across state variability?
Oh, goodness. I'm not, I'm not entirely sure what, so in terms of the limitations and exclusions, I'm not, I think there's actually not that many. The continuous enrollment is the biggest one. Whoever this is, feel free, I think I have my contact information on this, so feel free to contact me if you have specifics, but we actually were able to use a lot more states than most studies using these data, which I think is a big plus for this study. And yes, Medicaid enrollment has a lot of churn, so we did have to impose the 11 months, but a lot of studies do that. In terms of why 2019 data wouldn't be representative for like 2024, it's true that there are always Medicaid policy shifts, but you kind of have to take some slice of something if you want to start. So, I would say that we didn't know anything about disenrollment at this age before, and maybe it's changed in 2024, but we at least need a baseline. And I'm not sure if I answered that person's question, but whoever it is, feel free to contact me if you have more specifics.
I think you would expect that things would be quite different given the prohibition of Medicaid disenrollment during the pandemic era.
Sure. Yeah, if you looked at the 2022 to the unwinding in 2023, you certainly would see the disenrollment should be much lower, right? So I would think that you would see something much different. I mean, we intentionally didn't include we could have included up to 2022 and intentionally stopped at 2019 because we think that's a somewhat anomalous policy environment. So I would say that, and we don't have 2023 and 2024 data we don't have yet. So I think that this is probably more representative of sort of a general equilibrium type policy, but again, anything could happen, and policies change all the time.
Any more questions in person, online? If not, let's thank Dr. Cliff for presenting today.